Fred.
Good afternoon. I'm Fred Cerise, the Parkland, and the chair of THOT, the Teaching Hospitals of Texas, and that's the group I'm representing this afternoon. Thank you for the opportunity to address the committee. You've heard a lot of discussion already about the payment challenges and the dependence on supplemental payments. Let me tell you a little bit about the THOT hospitals and why those payments are so important to our members. While the THOT hospitals represent only about 5% of the hospitals in the state, we represent about 16% of the hospital days, 23% of the Medicaid days, and over a third of the uninsured days. So the Medicaid and uninsured patient population is heavily concentrated in our facilities. People think of these as hospitals, but in reality, we are large delivery systems. And so, for instance, at Parkland, we'll do 65,000 discharges a year. Hospital discharges on the outpatient side, we'll do 1.2 million clinic visits. That's primary care, specialty care visits that keep people out of the hospital. And so these hospitals also provide the majority of level 1 trauma, graduate medical education. So they're big health delivery systems with a heavy focus on Medicaid and the uninsured. If you look at some of the bigger ones like Harris and Parkland, anywhere from 75 to 80% of our patient population is or people who are either uninsured or on Medicaid. So these Medicaid payments and the supplemental payments become much more important when you have little elsewhere to turn to for those payments. We have county funds, Medicaid payments, and then the federal share of the supplemental payments that make up the vast majority of our reimbursement. And as has been mentioned, these are the hospitals that are providing the match through these county hospital districts, the match for the supplemental payments throughout the state. Which is which if you look in the Medicaid program, in the hospital payment program over time, you see a decline in the state fund contribution, an increase in the dependence on IGT for those payments, to the point where now over half of the match payments are being made through the county funds. So that's just a little bit of background, kind of the hospitals and some of our unique challenges. I want to add my voice to the thanks for the trauma add-on, the safety net add-on payments. Those were very helpful as we dealt with a reduction in the DISH payments. I would ask or suggest on the safety net add-on, the legislative language associated with the safety net add-on discussed making those payments in relationship to Medicaid and low-income uninsured days. The actual formula focused on Medicaid days and not the uninsured days, which places those of us who, when half of your patients are uninsured, it puts you at a disadvantage when those days are not included in that calculation, which I think was the intent, to cover those safety net facilities that are doing such a large percentage of the of your care that is that safety net care. As I mentioned, and I'll just give an example with Harris Health. The waiver payments become it's not an add-on for these safety net systems. They become an essential part of our budget. Harris Health, which is a $1.3 billion budget, this past year had a margin of less than 1%, which was only possible because of the waiver payments. Absent the waiver payments, Harris would have had a negative 16% margin, or a minus over 200 million margin. That's kind of that's the importance of these. They're supplemental, but they're essential to the operations of the major safety net facilities. I know I can tell you we're in the middle of our budget process this year at Parkland. We are projecting a deficit for 17. We've just put all of our departments on notice in the past couple of months to do a 4% reduction throughout the hospital so that we can make it work this year.
That sounds familiar.
I saw that. I wouldn't, when that went out, it sounded familiar to me as well. We did that about 3 months ago, because as we look, the challenges we're having is, as was mentioned earlier, the volume is common, the volume is still there, and as as you try to accommodate volume, when the volume consists of Medicaid, which pays at a % below cost, and uninsured, then that added volume becomes added cost, and so you try to accommodate the volume, but really incurring extra costs, and so we've had to step back midway through the year to try to squeeze a bit more so we can finish the year in a positive position. So it's and when that's 75 to 80% of your business, it's difficult to get those to make up the difference on another line of business, and so we're heavily dependent upon those payments. For the budget year this year in 17, we're in the process of, we're modeling reductions in Medicaid. You heard discussions around the NAIP program, the MPAP program, so we're modeling reductions, not inflationary increases, which again is going to put a strain on the amount of services that we can deliver. So as John mentioned, we certainly don't want to come with just problems, and we are committed to working with you and with the agency on solutions. Certainly you've heard that CMS is looking to address this through increased rates and through coverage. We know all of that's not possible, but we're interested in working on solutions on rates, which might include alternatives that are not GR to get there. We certainly are interested in working with you on that, and then on the UC side, we think, and when you look at the comprehensive delivery systems around the uninsured that you see with a number of THOT members, we think that we could provide alternative systems of care that perhaps could be a negotiating point with CMS, where they're interested in reducing UC funds if they're not for services that would otherwise be covered through a Medicaid expansion. Well, if that's not going to happen, can we offer the next best thing, which is an integrated system of care that perhaps they could negotiate around and not reduce those UC funds quite as much if we could deliver something close to coverage but not coverage. And so we've had some discussions with HHSC and with CMS, and we're interested in pursuing solutions both on the rate side and on the UC side.
Are you prepared to discuss any suggestions or priorities you all may have with regard to the rate enhancement, or any ideas that we might be able to start to work on?
Sure. Well, again, John mentioned making sure the calculations are correct. GR is always, a popular option, but as he mentioned, 40 other states do a provider fee that helps support the state share of match for rates, and that's something that I think is going to. The state has done that in pockets. Did that several areas last session. And I think that's something that's going to get a lot more attention this session, because of the position that we're in.
Okay. All right.
We certainly are interested in working on that and other solutions with you as well.
Great. Thank you.
Thank you.
Does that conclude your testimony?
It does.
Right.
Thank you.
Okay. I just want to make sure I don't want to rush you at all. But members, do you have any questions of either of these witnesses? That's really helpful testimony, and we look forward to working with you. And we hope that as you develop suggestions more thoroughly, especially with your discussions with CMS and with each other, that you will let us know, as you work with HHSC as well, that if there's something that we can study and work on, certainly between now and January, that would be helpful. And we really appreciate your insight.
Appreciate it. Thank you.
Appreciate that very much.